Good afternoon, everyone, and welcome to today's Fireside Chat. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center here at the University of Minnesota, your host and moderator for our monthly Fireside Chats. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these fireside chats to raise awareness, share knowledge, and highlight the people, research, and lived experiences shaping cancer care and outcomes across the cancer continuum. Today, we're honored to recognize Bladder Cancer Awareness Month. Bladder cancer is one of the most common cancers affecting the urinary system in both men and women. However, it occurs more often in men than in women. Yet many people know very little about its warning signs, risk factors, and how it is diagnosed and treated. So today's conversation will help us better understand bladder cancer from both the medical and the personal perspective. We'll discuss the risk factors, symptoms, what the diagnosis is like, process is like, treatment, survivorship, and then also the importance of listening to our bodies and seeking care when something just does not feel right. So to guide us through today's discussion, we are honored to be joined by two phenomenal speakers, Dr. Ahmadi and then Bukwon Holland. We'll first hear from Dr. Ahmadi. Dr. Ahmadi attended Tehran University of Medical Sciences for medical school, and then he completed his residency training in urologic surgery at Oregon Health and Science University in Portland, Oregon. He then completed a Society of Urologic Oncology Fellowship at the University of Southern California before he joined the University of Minnesota Department of Urology. Dr. Ahmadi specializes in open and minimally invasive management of complex genital urinary cancers, and his primary research interests focuses are in tumor marker-based management of bladder and testicular cancer. Dr. Ahmadi has also been recognized as a Minnesota Monthly Magazine Top Doctor in 2025, and then he was recognized as a Top Doctor for Women in 2026. He was also recognized in 2025 as a Urology Surgery Research All-Star. We're incredibly grateful to have him join us today to share his expertise and then also to help us break down the important topic of bladder cancer. As I mentioned, joining Dr. Ahmadi is Bukwon Holland. Bukwon is the CEO of Bukwon Peaks, a voiceover actor, a narrator, speaker, host, and MC, and live presenter based here locally in the Twin Cities. He's known for using his voice to inspire and connect. A proud cancer overthrower, Bukwon's life changed in October 2020 after being diagnosed with bladder cancer. His journey through treatment strengthened his purpose to advocate for awareness, early detection, and hope. He is also the voice of Ahmed Butler Foundation and a proud sponsor of the organization, which is dedicated to fighting pediatric cancer in honor of his late cousin. Today, Bukwon will use his voice not just for performance, but for purpose. He will share his cancer journey to uplift others and then help move us closer towards a future without cancer. We're so incredibly grateful to have you both joining us today. As I mentioned, we'll first hear from Dr. Ahmadi, but before I pass it over to Dr. Ahmadi, I'd like to cover just a few quick housekeeping items. Today's Fireside Chat will be recorded, as they always are, and the recording will be made available on the Masonic Cancer's YouTube page by next week, so you can rewatch the conversation or share it with somebody who you think might benefit from it. Closed captioning is also available, so you can turn it on by clicking the CC button at the bottom of your Zoom screen. For all University of Minnesota employees and spouses participating in the university's employee well-being program, you can earn your 200 well-being points by attending today's fireside chat by completing the form that I will be dropping in the chat shortly. And then we invite you to engage with us. So please use the Q&A feature at the bottom of your Zoom screen to submit any questions or comments that you have throughout the session. We have time carved out at the end to take questions with Dr. Ahmadi and Bukwon. All right, without any further ado, I'm going to hand it over to Dr. Ahmadi. The virtual floor is all yours.
All right, thank you so much, Amna, for the nice introduction. It's an honor to be here. This is great, and sharing this panel with Bukwon. Got to know him a little bit, so this is a great pleasure, Bukwon, to share this panel with you. And everybody else who took the time out of their day to just be here. I appreciate that. I'm going to share my slides. Can you see my slides okay?
Yes, it's just not the
Okay.
first.
Okay.
Yep, there.
Is it back to first one? Okay, perfect. So as Amna said, I'm a urologic oncologist. I'm at the University of Minnesota. I'm an assistant professor, and I, I do my practice mode. I see pretty much all cancers, but my research interest and most of my clinical practice is on bladder cancer. So just to give you a bit of an introduction to bladder cancer. So the topics I'm going to go through, just to kind of briefly go through the risk factors for bladder cancer, presentation of that, how we stage it, kind of briefly touch on the treatments of for non-muscle invasive and muscle invasive bladder cancer. Just for the sake of time, I'm not going to go into metastatic bladder cancer for again for the sake of the discussion, the time that we have. But if there are questions, I'll be happy to answer those. Then I'll touch base on some novel biomarkers, including circulating tumor DNA, which is the most exciting marker that we have these days. And at the end, I'll kind of briefly explain my research at University of Minnesota and what we do. And then, obviously, any questions that comes up. I'm going to start my timer too, like I said before, Tom, not just to make sure I stay on time. There you go. So bladder cancer is mostly happens in men. It's the fifth most common cancer. Some kind of reported it's the fourth most common cancer you can see in men. And usually happens at a later age. We see some really young patients as well, but that's really not the common kind of picture. About 80,000 new cases are diagnosed each year in the States, and those numbers, unfortunately, are on the rise. When we talk about the risk factors, the most important one, like a lot of other cancers, is smoking. We have patients who come in who quit smoking years ago, but they're still kind of to reverse that risk factor that takes years, sometimes just never reverse, is not reversible. So smoking is the main risk factor. There are a lot of exposures, especially to dye, that actually can put people on at the risk of bladder cancer. Like a lot of painters are at risk of that, especially the type of paints that we used to have or used to use years ago. Those can put them at risk of bladder cancer, chronic bladder irritation. In patients who have to use a catheter for a long time, they could be at risk of a special type of bladder cancer. It's called a squamous cell carcinoma. You could also get those from a special kind of infection from a worms, a schistosomiasis, that you can have it. It usually happens in Northern Africa. We don't have it here, but that's kind of very common in those areas. But again, not here. And prior radiation to the pelvis and some chemotherapy agent could also put patients at risk of bladder cancer. Radiation is one of those things that you don't really see the side effects of it, especially the secondary malignancy right away, but years down the road, you can actually see those issues. The way they usually patients present is gross hematuria, which what it means is that you see blood in your urine. It's painless. There's no pain associated with that. But if there's pain with it, it doesn't mean that it's not bladder cancer. There's no risk of that. It could be still the issue. The bottom line is that if you see blood in your urine, that's never normal. So if you see that, please don't ignore it. There's something going on that causes that. Hard workout, strenuous exercise, I don't know, heavy lifting, none of those should cause blood in your urine. So if you see that, there's something going on, so please see someone. Some of the urinary symptoms, when you go pee, if you just pee so often, if you have the urge to go, if there's a burning sensation, there are other causes for that that can kind of explain those, like a urinary tract infection can explain that. But if you treat an infection once or twice, they technically should not just keep coming back. You do the workup, there's no real reason for it. They can't really find an infection. Even if they find it, treat it, and the symptoms come back, again, there's something going on. So a more investigation is necessary. Again, that's not a typical presentation for bladder cancer, but there are certain types of that can present like that. So, for really advanced kind of forms of cancer, sometimes you can have some pain on the sides, weight loss, loss of appetite. These are usually happens at the kind of a later stage type of cancer, metastatic disease. When you go see a urologist or primary care physician with those kind of presentations, usually urine analysis it's warranted, so they look at that. They can also send urine for a special type of test called cytology that they look for more aggressive forms of bladder tumor inside the bladder, which is what we call it high grade. But if your cytology is negative, that doesn't mean that you do not have bladder tumor. There could be some there, but cytology is not very good at catching those low grade one or less aggressive ones. Imaging is usually indicated, especially if you see blood in your urine, no matter how old you are and what your age is. Usually we get some sort of imaging. It's a special CT scan that they give you contrast, and you can actually see the contrast kind of show and kind of light up the lining of the kidneys and ureters and the bladder. So that's you can kind of see if there's any feeling defects. So that's helpful. But gold standard for detecting bladder tumors is cystoscopy, or looking inside the bladder with a cystoscope. Let me see here. There you go. So that's what a cystoscope looks like. So it's a tiny. I mean, we call it tiny, but it's not. Maybe it's not very tiny, but has a camera at the end of it. So when you come to clinic, we can actually place it inside the urethra for both men and women and take a look at it. We usually kind of hook it up to a monitor so you can see it on the monitor as well, what we see, and kind of look at the tumor and diagnose it that way. Once we see a tumor, then the first step to kind of determine what that is and confirm the diagnosis, and also to determine the stage of the disease, we need to do a procedure that is, there's a name for it. It's called transurethral resection of bladder tumor, or there's a short form of that called TURBT. That's essentially we put the patient to sleep. We use we call that a rigid scope. We use that resectoscope that we go inside. And we use a special lube to kind of shave the tumor off. We try to get all the layers of the bladder with it so that we can determine how deep the tumor is going. So there are new technologies that we can use when we do these procedures, especially when we suspect there's a little more aggressive tumor just from the looks of it. We suspect that. There are special dye or contrast that we can place inside the bladder before the procedure. It's called Cysview. And that enables us that when we do the procedure, we have this special tower and special scope that it can turn this blue light on. And if there's any suspicious lesion, it turns pink. That doesn't mean that you have cancer if it turns pink, but there's like high specificity for that, or it's very particularly specific for bladder tumors. So, but infection can cause that. So that's not 100% accurate, but it helps us in certain situations. When we send the cancer to the pathologist, they look at it under a microscope. There are certain subtypes of bladder cancer that they kind of recognize and report. That the most common one used to be called transitional cell carcinoma, but we call that urothelial carcinoma now. About 90% of the bladder cancers are like that. The second most common one is a squamous cell carcinoma. As you can see, about 5% of those, usually, as we talked about, is linked to chronic irritation of the bladder. There's some other subtypes that you can see as well. And sometimes the bladder tumors can differentiate into different types of tumors. And There are some of those called micropapillary, sarcomatoid, plasmacytoid. Those are typically a more aggressive types of bladder cancer if that happens. Besides recognizing the main subtypes, they can also tell how aggressive the tumor appears just purely based on the looks of it. And we call them low grade versus high grade. And obviously, high grade, that distinction is important because we know high grade tumors tend to be a little more aggressive, maybe become more invasive and go to the deeper layers if they haven't already, and they're at higher risk of metastasizing and spreading to other parts of the body. When it comes to the staging, a lot of it depends like how deep the tumor goes to the layers. So these are the layers of the bladder that you can see. That last layer that says fat, that's essentially outside the bladder. So we don't really want to see that when we do this procedure as we go inside and kind of shave off the tumor. But these are very important kind of staging and classifications for us to determine what type of treatment is necessary. As you can see here, if the cancer is within that superficial layer, we call that either TA or another special cancer, sometimes called flat lesion or CIS, which is short for carcinoma in situ. And also the one that go to the second layer, which is called lamina These are the ones that we kind of put them all in the one category of non-muscle invasive bladder cancer, because literally what it means is that it hasn't gone to the muscle layer yet. These are the ones that we can essentially just do the treatment and put the medication inside the bladder and treat them that way. But when it goes to the muscle layer or beyond that, then we're just going to a completely different category as far as the treatment options go. And again, we talked about this blue lights technology, and the reason it's important for us, that flat lesion that I mentioned or carcinoma in situ, that's very particularly helpful for that situation. We've shown in the studies in the past that more than up to 46% increase in detection of those carcinoma in situ when you use this technology, because a lot of times you just can't tell, as you can see by these pictures. It's very hard to kind of see those lesions, but the blue light actually showed them really well to us. Again, when it goes beyond the bladder and it goes to the muscle, then it's at risk of spreading beyond the bladder itself. One of the most popular spots for bladder cancer to go to is lymph nodes. And these pictures kind of shows where the lymph node chains are and how they're connected to the bladder. And those are the ones that usually bladder kind of spreads to. And it's still a stage 3 because it has gone beyond the bladder, but it hasn't gone further up. So we still kind of can do with intent to cure, as we call it, meaning we can cure someone even if they're spread to lymph nodes already. But once they advance even more, they can go to other structures. They can locally advance to the structures adjacent to the bladder, which are different structures in men and women, as you can see in this picture. But they can also go to other parts of body, to liver, lungs, and obviously those are a more aggressive disease. And as for now, we don't call them like any intervention we do, they're not going to be cured. We're just going to manage it and kind of make sure it doesn't spread more than that. So let's talk about the treatment options for non-muscle invasive bladder cancers, the ones that it hasn't gone to the muscle layer. For years, I'd say probably 30, 40 years, we've been using this BCG, which is, as most of you know, it's a vaccine. In a lot of countries, they give it to babies to prevent tuberculosis. Fortunately, we don't have that problem in this country, so we use it for a different purpose, and this is one of those. Essentially, what you can do is that you can place this medication inside the bladder, and it triggers the immune system as a vaccine should. And the immune system actually gets triggered and works against the cancer cells. And this is essentially the first form of immunotherapy that's now it's a hot topic. Everybody talks about it for different types of cancer. We've been using it for 30, 40 years. But it's all controlled within the bladder. It's all contained there. Because as you know, bladder is just a storage unit. So nothing gets absorbed from the bladder. So we kind of take advantage of that feature and so that we can put medication inside the bladder without them being absorbed systemically into the bloodstream. Typically, patients wait a little bit until they're done with surgery. They get these medications for 6 weeks in a row inside the bladder. They go to an infusion center. A catheter is placed for them. The medication is placed, and they let it sit there for about a couple hours, and then they drain it. They wait about 6 weeks. They come and see us in clinic so that we make sure that they're responding to treatment. And then based on the stage of this disease and how aggressive it is, we continue those treatments for shorter kind of longer intervals between the treatments, but shorter courses of treatment for sometimes a period of a year, sometimes a period of 2 to 3 years. Again, depends on the stage of the disease. But there are certain tumors that they don't respond to BCG. Some of them respond initially and then stop responding and they come back. As you can see, we call them BCG unresponsive. Some of them are refractory, meaning they never respond to BCG. Those tend to be a little more aggressive and more challenging to manage because at least they were more challenging to manage for until a few years ago. Because the cancer just kept progressing despite getting BCG. So at times it feels like you're wasting time by giving these medications. But we had a hard time in the past to recognize or identify those patients who are not going to respond to those. One of the medications that you could offer to those patients is a combination of chemotherapy medications, gemcitabine and docetaxel. These are pretty well-known chemotherapy drugs. And again, we mix them, or we can just sequentially put them inside the bladder. Very similar kind of course of action. This is for the first 6 weeks with BCG. The way they work is different because chemotherapy drugs are toxic to cancer cells themselves. They don't trigger the immune system, so they just work differently. But the course of action is very similar. You get them for 6 weeks at an infusion center. Again, wait a little bit. We'll take a look at it again. And then, sorry, this light goes off. So I'm just going to turn this back on. There we go. My apologies. Uh, so, um, so yeah, but again, they come back to clinic. We'll take a look at it again, and then we assess the treatment and response to treatment. There was a trial. It's close to enrollment now that we had it open at the university as well that compares this gemcitabine and docetaxel to BCG in patients who've never received treatment inside the bladder, not necessarily in the setting that they don't respond to BCG anymore, but more of a kind of a head-to-head comparison. So we'll see the results. Hopefully, will come out in 2 to 3 years, and then we'll know exactly how effective it is. We think it's as effective as BCG, but the trial results will show that. And there are other options for BCG, unresponsive or refractory disease. The main one that we had for years was Valstar or Valrubicin, which was really, as you can see at the numbers, the response rate wasn't that great, but that's the only option we had. And we really didn't have anything until a few years ago as like the bladder cancer became more of a topic of a conversation and people started looking into this. And now we have 4 medications that are FDA approved for this specific subgroup of patients who don't respond to BCG. And as you can see, we have great increase in the response rate as we go through these kind of new drugs and we understand the disease better. So now we're at the point that we have this new medication called Inlexo that you can get up to 82% complete response with it in people who never responded to BCG. So this is exciting time, and we're making a lot of progress in bladder cancer. And I promise you in the next 3 to 4 years, you're going to probably have 3 or 4 more drugs added to this list. So this is a really exciting time for us so that we can help the patients better with more effective treatments. Now let's kind of switch gears and talk about muscle-invasive bladder cancer a little bit. And again, usually muscle invasive, the main concern is that it's gone to the muscle layer, so there's a higher chance of these, at least microscopically, to get outside the bladder and go to the circulation and the bloodstream, and eventually causing like clinically evident metastatic disease. So the idea was that essentially for muscle invasive bladder cancer, that we give them some treatment ahead of time that we call that neoadjuvant or upfront systemic treatment. To try to control that microscopic or micrometastatic disease outside the bladder and then kind of address the bladder later. As you can see, the early kind of days that we started working on this, cisplatin was the drug that everybody was using, and it dates back to 1974. And as we made progress, again, we came to 2000s, we came with another regimen, we started combining chemotherapy medications, it was kind of a quiet space. We were just going back and forth between a couple of regimens, and until recently, that then immunotherapy became, again, it's a very, very exciting topic, that it was very effective in a lot of cancers. And then we started kind of combining those chemotherapy medications with immunotherapy medications. And as you can see here, there's a very rapid acceleration of like all the new that combination of medications that come to our kind of arsenal, and we use them for bladder cancer. Um, then, as you can see here, these are the newly approved medications that by FDA. The most exciting one that everybody's talking about now is a combination of a targeted treatment. It's called PADCEV, or we call that a short form of that very fancy name is EV, and pembrolizumab, which is an immunotherapy, or commonly known as Keytruda. You can see that the earliest study that there's it's not still FDA approved, but shows that people who typically were used to get chemotherapy and they had like 30% response rate inside the bladder, meaning everything is gone. Now we're getting close to 60% for those patients. So that's huge in this population. We think we can make it even better. So again, there are a lot of kind of new drugs coming to horizon for us, and we can use them. It's available for us for patients to use. So again, really, really good news for bladder cancer patients. On the other side of it is when the patient is done with treatment, there are a lot of development in terms of what type of treatment we can offer them afterwards to control the disease and make sure the cancer doesn't come back and consolidate the response to the upfront chemotherapy or systemic therapy and surgery. And as you can see here, these are all the new medications that are available to us, and there's significant increase in reducing the risk of recurrence of the cancer, and most of these improve the overall survival from the cancer as well. But in between those two treatments is a very morbid procedure, radical cystectomy, which is one of the most complicated and complex surgeries that we do in urology. There's about 70 to 80% complication risk. Not every complication is high enough that patient gets admitted to the hospital. Some of these are minor complications that are easily managed, but again, they all add up. So 70 to 80% complication risk for that. But a lot of the issues is that a lot of patients that we see, there are studies showing that up to 50% of patients who get muscle invasive bladder cancer, they're not really candidates for cystectomy. And due to a lot of factors, other diseases that they have, or very frail, they can't have these. So in those patients, there are other options to address that. A combination of chemotherapy and radiation is an effective treatment. It believes that it's inferior to surgery and getting chemotherapy, systemic therapy first and surgery, but there are studies showing that there might be actually at the same level in terms of effectiveness. There've never been a head-to-head comparison of these two in a trial setting, so we don't know. If somebody's not as candidate to receive chemotherapy or any systemic treatment, radiation alone could be an option. It's suboptimal, but could be considered. And maximal TURBT, meaning when we go in to shave off the tumor, we do our best to get whatever we see that looks abnormal and just kind of keep an eye on things. And again, none of these are optimal managements, especially radiation alone and TURBT. But again, sometimes you have to make that choice. In patients who have a cystectomy, we've got to figure out a way for the urine to come out. So there are different things that we can do. We typically use part of a small bowel and sometimes a combination of a small bowel and a large bowel to create a pouch. In this corner here, you can see that's called an ileal conduit. They use 10 to 15 centimeter of the bowel to create this diversion. Ureters gets connected to one end of it, and the other ends come outside. And as you can see in this bottom picture here, there's a bag that sits on top of that. It's called an ostomy bag, and the urine drains into it, and you can empty it. There's other pouches. We can actually create a pouch. We call that a new bladder out of a small bowel, and kind of make it into a round reservoir that looks like a bladder and sits exactly where the bladder was. We can also create a pouch out of small bowel and a large bowel and connect it to the belly button. And as you can see here in this middle picture, that patients can place a catheter through and empty the pouch that way. there are pros and cons to each one of those. I won't go into details of that. So I just wanted to show you some pictures. Now with advancement in robotic surgery, we can do a lot of these procedures robotically as well. We can do the conduit robotically. We can do the neobladders or even the other pouch robotically as well. The main benefit that has been shown in doing a robotic surgery versus open surgery is usually the amount of blood loss that is less with robotic surgery. But again, besides that, in terms of the effectiveness of the surgery and the total recovery time, they're pretty much at the same level. As you can see, usually patients spend 4 to 5 days in a hospital. About 6 to 8 weeks of recovery is expected. Some people do much better and they recover so much faster, but we usually set the expectations for the first 6 to 8 weeks, they're not going to feel great. So, and most of that comes down to using the bowel for the diversion parts. As we talked about, 70 to 80% complication risk. 15 to 20% of those are major enough that patients get admitted to the ICU or they need a second procedure to kind of address the complication. The main reason the patients stay in a hospital longer than expected is for bowels are not ready to move and they're not passing gas, they're not having bowel movements, and they feel bloated. We call that ileus. And there are two main reasons for these patients to come back to the hospital. Urinary tract infection is common in these patients and also dehydration. And again, that usually happens for the first 6 to 8 weeks and things start to kind of settle. There are a lot of efforts to improve the outcome, make sure the patient's complications are low and the readmissions rates are even less, or maybe it stays at the same time, and try to get the patients home earlier than 4 to 5 days. There's so many components to these. We call these enhanced recovery after surgery protocols. Now we have a society and we have guidelines that we write. And I was fortunate enough to be part of one of the first teams in the country who actually developed one of these enhanced recovery protocols, and currently serve on a guideline panel for these enhanced recoveries after surgeries as well. And now let's talk about the biomarkers. I think I'm still on time. That's good. Again, there are a lot of things that we work on, but the most exciting one, as I mentioned earlier, is circulating tumor DNA. Just to cut into simple words, what that is that every single cell in the body, when they die, they just shed all these different fragments into the bloodstream, including DNA. There are cell-free DNAs that essentially every single cell, no matter if it's cancerous or a healthy cell, will just shed those into the bloodstream, and you can catch those. We can call those cell-free DNA. But the circulating tumor DNA are very specific to the tumor cell. So you can actually, now we have the technology to detect these and detect a very, very small amount of tumor in the bloodstream. And theoretically, that should help us a lot with a lot of things that we're going to get into as we're going through this presentation. How do we measure it? To put it very simply, they just isolate it from the bloodstream. They get a blood sample, they centrifuge that to separate different components of it. And then they extract these cell-free DNAs, and then they use these advanced technologies to kind of get those circulating tumor DNAs. And there's very, very kind of convoluted technologies that they do that. There are different ways to kind of report this and look at these genetic components. There are some companies such as Signatera that is pretty well known now that they actually get a tissue sample. They uniquely identify the genetic components and mutations specifically for that particular patient and that tissue, and they essentially map these unique genetic fingerprints for the patient. There are some other companies such as Garden 360 that they don't use that technology, but they have this preset panel of some genetic mutations known to bladder cancer that are very commonly detected, and they can kind of compare that to this and run it without needing any prior tissue sampling. Why do we need it, and why do we think it's good in bladder cancer patients? We have a lot of staging limitations, as I showed you. We have just some CT scan MRIs that we get, but they won't really detect much unless the cancer is big enough for us to see. And also cystoscopy. We'll go in with our eyes, we'll look at it. We have some enhanced cystoscopic technology such as blue light that we use, but again, it's not perfect. So we think this is going to help us from that perspective. it can early detect the recurrence of the tumor early on before it gets to the point that we can actually see it on imaging or see or a cystoscopy. As the patients go through treatments, we can actually monitor the treatment response and see how they do. And if they respond well, then we have a lot of hope that we can actually help them once we do the surgery. At some point, if they're necessary. And then the other thing is that bladder cancer it's a very heterogeneous tumor, meaning there are so many different components and genetic components to it. And even if in a single person with different tumors, those different tumors have different genetic components. So these we can actually, by having those tissues, we can actually identify and roadmap a very specific and personalized genetic fingerprint for each tumor individually and try to monitor them at the same time. And that's a prime example of how we can use this technology. This medication, which is immunotherapy called tislelizumab. There was a trial that showed it wasn't effective even if you give it to the patients after surgery. But once they kind of started looking into details of that, they saw that if the patients are ctDNA positive, this medication is actually extremely helpful. So now it's indicated in patients with ctDNA positive after surgery. And at the end, I just want to kind of talk about our research and what we do at University of Minnesota in our department as far as the research goes. One of the trials that are clinical trials and clinical research that we do, one of the main ones that we've had it open for about 2 years now, we've looked at effect of antibiotic prophylaxis in patients who had this surgery done, whether they need to go home with an antibiotic course or no. And Jonathan Sussman, one of our chief residents, he was the main person in charge of this trial and did a great job. And we recently presented that at the American Urologic Association. He had a podium presentation and got a lot of positive feedback and press coverage as well. The other study that we're doing, we made an ostomy model with the help of our medical device center. The patients who are going to have this surgery, they can actually have this model and practice with it. And we've shown that we can actually, they have a better kind of satisfaction with this. And lastly, I do some translational research as well with some of my great minds up there that have their pictures there. They're my mentors and collaborators. What we're trying to do, we're trying to tailor the number of cycles of treatment that people receive using this ctDNA technology so that maybe people don't need 4 cycles of systemic treatment ahead of time, or maybe they don't need anything afterwards. And as far as the non-muscle invasive goes, we're trying to roadmap using AI technology and some very advanced technology to kind of extract and identify certain receptors that then we can kind of map those and really try to individualize the type of treatment the patients need to get and kind of the order of treatments that they need. And at the end, I just want to give a shout out to my research team at the university. We cannot do any of this without them. They've done a great job. And thanks again for giving me this time to talk about these things. That's my contact information. So please reach out. So obviously ask me questions here as well, but please reach out if there's anything else that I can help with or I can answer. Thank you.
Thank you so much, Dr. Ahmadi, for that incredibly informative and thorough overview of bladder cancer. I personally really appreciated how you broke down the risk factors, the warning signs, how it clinically presents, and then also how it's diagnosed and staged, and then the treatments that are available. But I also appreciated learning more about all of the emerging research that's happening at the University of Minnesota, and the advancements that are happening that will improve patient outcomes in the very near future. So now we're going to turn it over to Bukwon, whose story will remind us of the very real human side of this disease. Bukwon, thank you for being here today and for your willingness to share your story.
Thank you, Amna. Thank you. I really appreciate this. I was okay till I saw the slides, and I thank you for having me. I was doing just fine. Then I had
You got
reminders,
this.
and I had reminders. So I'm gonna get through this, but I'm dealing with a feeling right now I haven't felt before, you know, mentally, and I'm gonna get through this. Thank you for having me. I'm blessed. I'm honored to be here with y'all to tell my story. My name is Bukwon Holland. I am a voiceover actor, narrator, live announcer, MC host, and speaker. But most importantly, the reason why I'm here today is because I am a bladder cancer overthrower. Thank you, God. Thank you. Not everyone get to say those magical words, but I'm grateful and I'm honored to be able to say that every single day. I want to thank the Masonic Cancer Center at the University of Minnesota, Dr. Ahmadi and his entire team. Um, just to tell my story here is just truly it's a testament that cancer is no joke. It's no joke. I had my first cancer running October 5th, 2020. I remember that day like it was just yesterday. When I went to the potty room, I saw blood. I seen a lot of blood. My wife and I were scared. And so we did go to the ER. They ran tests, but they found nothing. And it's one thing to see something wrong, but they tell you nothing is wrong. That don't make you feel any better. And that made that fear even more real. But thankfully, I was able to get an appointment the very next day with a urologist. And her name was Dr. Dixon. Ironically, I felt like if a name like that, I'd be in good hands. And so she reviewed my labs and she talked very intentional with me. And she let me know that she would have to do a cystoscopy. And I said, well, I'll have to wait a while to do a cystoscopy. Do I need a pre-op? She said, no, you don't need a pre-op. We can do it now. And I said, without sedation? She said, that is correct. And a cystoscopy is a camera that goes through your urethra, past your prostate, because that's what it just felt like, that action I just gave you that. That, yeah, it make you feel just like that. And then it goes into your bladder. And I'm looking at the monitor while Dr. Dixon was talking to me about what she saw. And she seen a tumor and she thanked me for coming in because it was the culprit. It was a large tumor. And I was like, wow, that's inside of me. I wouldn't have even thought that one day I had a normal life and the next day I found out that I had cancer and I had multiple tumors in my bladder. I had had surgery, then immunotherapy. And I'm blessed. I'm truly blessed that I didn't have to have my bladder removed. And I didn't need chemotherapy or radiation. But this journey was actually one of the scariest things that ever happened to me. And I realized cancer is a nasty disease. It just don't affect the person. It affects the whole family, everyone around them. In 2015, I had a 6-year-old cousin, Ahmad Butler, who had brain cancer, and he passed away. I thought it was very unfair that a child could develop brain cancer and then cut his life short. But his grandmother didn't let his legacy die. She developed and founded the Ahmad Butler Foundation, and you can find that at ahmadbutlerfoundation.org. It's an amazing organization. And my Aunt Lisa, who was like a second mother to me, passed away from pancreatic cancer. And that was like the most aggressive cancer known to mankind. And this is a woman who taught me how to love, who showed me what life could really mean if you're happy. And it broke my heart because I couldn't help her. But these kind of experiences taught me that cancer don't care about age. It don't care about how good of a person you are. It just comes. And that's why we have to be proactive about it. I know that you have to get your cancer screenings. Don't wait. Don't make excuses. Ask questions about your family history. That's really critical. If your mom, dad, grandparent, cousin, or sibling has ever had cancer, any cancer, tell your doctor. That information do matter, and it could save your life. When I went to the urologist, I did tell her about what was going on, leading up to, and it wasn't nothing, but I believe that had I waited after I seen blood, I wouldn't be talking to you with my own bladder. Early detection literally did save my life, and I can honestly say I'm fortunate enough that I did, pass blood to get in to go see. If anybody have risk factors, you have to get screened. I can't say that enough. If you notice anything unusual, blood in your urine, pain, get checked. Don't be afraid. The fear of the unknown is worse than the fear of the diagnosis. And I know. But I definitely want to take a moment to honor the caregivers. Y'all are so important. If you're caring for someone with cancer, a spouse, a parent, a child, or even a friend, you are the caregivers. You are the true heroes and sheroes. You are doing some of the most important work in the world. My wife stood by me through every appointment, every procedure, every scary moment. And caregivers carry a burden that often goes unnoticed. And you also deserve support, the rest, and the recognition. So I thank you from the bottom of the core of my existence. Thank you. Thank y'all for your love and the sacrifices that y'all give. And the healthcare professionals, the doctors, the nurses, the technicians, the support staff. You guys are the reason why we are alive today. So give yourselves a round of applause, a pat on your back, or whatever you want to call it. But it's important that you know your history. Don't put off any screenings, especially once you find out that cancer runs in your family. Early detection is very, very important. And I also want to send a shout out to the Masonic Cancer Center at the University of Minnesota. Y'all doing some incredible work. Dr. Ahmadi and his team. Keep saving lives and keep making the world a better place. I was a cancer patient, but I refuse to let cancer be my only identity. I am an overthrower. Thank you, God. I am a voiceover actor. Thank you, God. I'm a live announcer. I'm a speaker, but I'm also a son, a family member, and a friend. I'm a man with dreams and plans for the future. And today, if someone wants to make sure that others, may be someone in a room, in any room that you at, get screened. Early detection is so important. I hope my story did inspire somebody to ask questions about their family, not to put off any symptoms of unusualness. You're special. Don't cheat yourself. Treat yourself. Treat yourself to the doctor. Go get your ass checked. I mean it from the bottom of my heart. I thank y'all for having me. I wish each of you well. Keep making the rest of your life the best of your life. Chin up, crown straight. Thank you.
Thank you so much, Bukwon, for sharing your story with such openness and honesty. I mean, your journey is such a powerful reminder of the importance of listening to our bodies and seeking care when something isn't right. And so
Yeah,
we
thank
really
you.
appreciate your vulnerability and your willingness to use your voice to help others. So now in the time that we have remaining, we're going to transition to the discussion portion of our fireside chat. I'm going to bring Dr. Ahmadi back to the conversation. And then also, if folks have attended previous fireside chats, not a fireside chat discussion without getting our fire started. So I'm going to get the fire started and then we'll kick things off. We've had quite a bit of questions already submitted, so I think we'll start with those. Dr. Ahmadi, this question is for you. Can frequent UTIs in women be a risk factor for bladder cancer?
Uh, Good question. Yes, in a sense, mostly not necessarily frequent UTIs, but if it's chronically happening over a long period of time, it could cause bladder cancer. But that's rare for that to happen, to be honest. But it could be a symptom of a bladder cancer. So again, as Bukwon kind of said once, just over and over again, these are the things that frequent UTI, if there's no good reason why somebody's having frequent UTI, they need to be checked out. And especially in women, it's not uncommon for them to have frequent UTIs. And then at the baseline, there's this problem that there's might be a bladder tumor causing that.
Okay, thank you for that. Okay, so this question is for both of you. We know, and Bukwon, you spoke of this, but we know that men are less often likely to seek medical care early or talk openly about changes that are happening in their health. So, from both of your perspectives, what are some ways that we can better encourage the men in our lives to pay attention to urinary symptoms, to speak up when something feels different, and to seek care sooner? Bukwon, I'll start with you, and then Dr. Ahmadi, I'll let you answer as
Thank
well.
you. That's a valid question. I thought I was the first person that ever had bladder cancer. I haven't heard of it. And my grandmother, a lot of her siblings, her her brothers passed away from some form of cancer, but they found out later in their life. And I that having older cousins, they say, hey, and they're in the medical field, they like get yourself checked. Especially my cousin Thenia, she was a nurse. She was like, get yourself checked. So it started with the colonoscopy at the age of 30. And then 35, they found polyps and then more polyps. And then they found diverticulitis. And so that really kept me in tune about what's going on with my body. Because these are organs and any lump, bump, go get it checked. Like headache, any unusualness even in the stool area, like that, those are good detections of like what is right, what is wrong. And your body, we're all human. I can't get too explicit, but go get your butt checked. I mean, honestly, put on the gown. It won't hurt. It's not as bad as I thought. And I'm gonna be honest, I never thought that I'd be like, oh, I can't wait for my colonoscopy. But I can tell you that prep work that'll make you feel much better. Honestly, you feel light and like you start floating and everything. But
Mhm.
I probably got off sidetrack, but I apologize. But I'm passionate about, you know, getting yourself checked, about the
Yes.
screening and the history of your family. That's so important.
Yes, definitely. And
And
I think
and and,
it's
and I just need to say this to the brothers, any brothers out there that's watching this YouTube. I don't know where it's gonna go. Listen, there's nothing, as they say, I'm gonna say what the young folks say, zesty about putting on that gown, about having that camera go in any hole. I mean, just get, because it can save your life. You can spend time with your children. And I mean, if you research how to work, Facebook or Instagram, research how cancer could affect your life. You know what I mean? Find
Mhm.
out Find out if, that feeling that you have is something worth checking on. I just say go to doctor. Go to doctor. HCMC is now open. I just seen it on the news that they're going to stay open. They got free care. That's the baseline of treatment. After that, they'll write you referrals. They'll send you to Dr. Hamed. Trust me, he the man. Look at him. Look, he got his game face on. See,
Yes.
told you.
Thank you, Bukwon. Really amazing points, stressing the importance of knowing your family history because, as you mentioned, that means you could get screened a lot sooner for certain cancers. But Dr. Hamidi, please, what tips do you have so that we can encourage some of the men in our lives to go seek care?
Yeah, I just echo what Bukwon said. I think a lot of it comes from lack of awareness of exactly what those symptoms are. I think engagement, just be like for us, especially on our side, just to be more vocal and try to get everybody engaged and make sure they're aware of the symptoms and what those are and what to look for. It's very, very critical. Just want to add, we do have actually a seminar coming up that we had a grant from university just to enhance the community involvement. We're just going to focus on the Somalians, actually, that we're going to do some GU cancer, just genitourinary cancer awareness campaign, which is we're just going to do some teaching and handouts so that they're aware of what to look for. And that's just a small portion of what we can do to get everybody engaged. And as Bukwon said, it's just this is stigma around going in to see a urologist, and I'm the first to admit it's a scary thought to go see someone. And if you've heard somebody's story that they're gonna place a scope and take a look inside, that's gonna hurt. Yeah, that's all true, and that's very true. Seeing a doctor in general, there's a lot of unknowns coming with it that you just don't know what you're getting into. So for a lot of those reasons, people just try to ignore it and say, maybe this is nothing. Maybe I don't have to go pick up the phone, try and make phone calls, make an appointment, go see someone, and then get these medical bills and all that that's going to entail. Obviously, HCMC, that's a huge resource for people if it's free for them to go, but financial reasons also is one of the very, very important things that we have to acknowledge in our healthcare system that is present, and we just haven't addressed it enough, I think. But again, I think awareness is the best thing we can do for people to be more engaged and understand what those symptoms might mean.
No, truly. I mean, knowledge is power. So I appreciate what you just shared, Dr. Ahmadi. So I am so sorry we're not going to be able to get through all the questions. There's so many that are being submitted. So apologies in advance. But I
I got the
think
time.
well, before we wrap it up, let me ask you both one final question. So Dr. Ahmadi, I'll ask you first, but what is one key message that you hope our audience will leave with today when it comes to bladder cancer awareness, health in general?
I think my biggest message is that please don't take this lightly. If there are symptoms, please see your physicians. We can help you. Bladder cancer, again, I presented a lot of the data. Maybe sounds to a lot of people scary, but there are a lot of these people present at earlier stages. So if we catch this early, we can treat it. You can be completely cured from this. So if you help us coming in early and you help us greatly, if you do that, then we can actually help you and get you really cured from this. So that's, I think, the biggest takeaway from this on my side.
That. Bukwon, what about you?
Yeah, I say
One
definitely
message you
get.
hope folks
Yeah, I
take.
hope that somebody can say, you know what, let me talk to grandma, find out, and then tell a doctor. And then that's the first step of getting treatment. I mean, go to U of M, go to your healthcare provider, explain that to them. It's very, 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 very important. So, and don't be afraid. Honestly, that cystoscopy was worse in my mind than the actual procedure. Honestly, it wasn't that bad. After one of my procedures, just this past February, I said, when she pulled it out, she said, "Oh," I said, "Oh, that's the best one yet."
All right,
It's to
folks.
make
Well,
life.
yes, it seems like we're gonna have to bring you both back for a part two to get through all of these questions. So stay tuned, folks. In the near future, we might be inviting Dr. Ahmadi and Bukwon back. But I think this is a really meaningful way to close out our conversation today. Thank you so much, Dr. Ahmadi, Bukwon, for joining us today, for your openness, for your expertise, and your willingness to share your experiences and knowledge with our community today. Love you repping that shirt, Bukwon. But these fireside chats are made possible truly by incredible speakers like both of you, and to our audience who continuously show up to learn, to ask questions, and to bring these conversations back to their families and their communities. So before we officially close, I just have a few quick reminders to share. So we would greatly appreciate if you could complete a brief survey. It will auto-populate as soon as we close out the Zoom webinar, and then it will also be included in the follow-up email that will be sent out tomorrow as well as next week. Your feedback truly helps us continue improving the series and to bring you timely and relevant cancer education topics to our communities. Again, if you want a part two with Dr. Ahmadi and Bukwon, let us know in the survey. And as a small token of appreciation, individuals who complete the survey can enter into a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And then we hope that you'll join us for our next Fireside Chat on June 18th, same time, same place. We're going to be talking all things acute myeloid leukemia with Dr. Zohar Shaks in honor of AML Awareness Month. The registration link will also be included in the follow-up email that will be sent out tomorrow. And then I also failed to mention this, but Dr. Ahmadi's slides will also be shared in the email that will go out tomorrow. And if you'd like to stay connected with the Masonic Cancer Center, be sure to follow us on all of our social media platforms to learn about upcoming events and also resources from the Office of Community Outreach and Engagement. Thank you, everyone, for spending your afternoon with us. We truly appreciate your time and engagement, and we look forward to seeing you in June. Take care, everyone.
All
Hi,
right.
Mom.
Thank you.